huge honor for me to do this here, and I look forward to an engaging moment talking about thyroid disorders. Now, thyroid disorders is a very, very common group of diseases that affects millions of people worldwide, but still, it remains one of the most underdiagnosed and undertreated conditions in primary care. Um, this short lecture is just to remind us of some key aspects of the thyroid gland and some disorders that affects it. For this lecture, I'll just quickly look at the introduction, and the introduction would involve a short overview of the thyroid gland, what thyroid disorders are, then focus primarily on hyperthyroidism, its clinical presentations, investigations, treatment, hyperthyroidism too, clinical presentation, investigations, and treatment. That would be the the outline for the lecture. So without wasting time, yes, I have a fine picture here. Now, the thyroid gland is a butterfly-shaped endocrine gland that's located in the arterial neck under the larynx. It spans the region between the C5 and the T1 vertebrae. Consists of two lobes that are like connected by the isthmus, and it's responsible for producing the thyroid hormones. I'm sure most of us have heard about the thyroid hormone, and thyroid hormone regulates metabolism, growth, and development. Briefly talking about the arterial supply, the thyroid gland is supplied by the superior thyroid artery, which is a branch of the external carotid artery. Also by the inferior thyroid artery, which is a branch of the thyrocervical trunk. It's also supplied by the inferior thyroid artery, and in rare cases, the thyroidema artery too supplies the isthmus and the lower parts of the thyroid gland. Now, the venous drainage is by the superior, middle, and inferior thyroid veins, which drains into the internal jugular vein and the brachiocephalic veins. Briefly, the thyroid is innervated pathetically by the superior, middle, and cervical ganglion. Then parasympathetic innervation comes from the vagus nerve. Okay. Now moving briefly to functions of the thyroid gland, because knowing the function of the thyroid gland will give us an idea the extent of presentation and damage a disorder to that thyroid gland could cause. Now, the thyroid gland produces tyrosine, that's the T4, which is like the most abundant hormone produced by the gland, and also the triiodothyronine, that's the T3, both of which regulates basal metabolic rate, protein, fat, and carbohydrate metabolism, growth and development, particularly also in the nervous system. The thyroid gland also produces calcitonin, which helps in the regulation of calcium homeostasis. Now, what are thyroid disorders? The main discussion for tonight. Thyroid disorders are conditions that affect the structure or function, or both. It could affect the structure and function at the same time of the thyroid gland, leading either to hyperthyroidism, which in case is like the overproduction of thyroid hormones, hypothyroidism, underproduction of these thyroid hormones, structural abnormalities to like goiter, nodules, or cancer, autoimmune conditions like Graves' disease, Hashimoto's thyroiditis, and so on. Now, these disorders can significantly impact a patient's quality of life, and it requires prompt diagnosis and prompt and comprehensive management. Without wasting time, let's look at the two thyroid disorders that we'll be talking about tonight. Let's start with hyperthyroidism. Hyperthyroidism is defined as a condition characterized by excessive production and secretion of thyroid hormones. Remember, the T4, which is thyroxine, and the T3, which is a triiodothyronine, leading to a hypermetabolic state. Now, some of the causes of this excessive production and secretion of thyroid hormones by the thyroid gland include Graves' disease. Graves' disease is an autoimmune condition with the thyroid stimulating hormone receptor antibodies, which is the most common cause of hyperthyroidism. Hyperthyroidism can also be caused by toxic multinodular goiter, which is like an autonomous nodule producing excess thyroid hormone. Toxic adenoma also can be like a single hyperfunctioning thyroid nodule stimulating the thyroid gland now to produce so much of this thyroid hormones. Now, thyroiditis, that is the inflammation of the thyroid gland causing transient hyperthyroidism. It could be like subacute, postpartum. Yeah, that's after pregnancy. Patients can have thyroiditis. Now, exogenous causes like overuse of thyroid hormone replacement or iodine containing medications could prompt the overproduction or oversecretion of thyroid hormones. Now, for the management of a patient with hyperthyroidism, like most of us know, it involves taking a comprehensive history, examination, and also investigations. Now, taking the history involves the biodata, obviously, the location um, where this person stays. You could take the presenting complaints, take social history, family history, even the past medical history are very important. Sorry, are all very important in arriving at a diagnosis. Now, also, patients with hyperthyroidism, there are specific signs you can find on examination, especially during general physical examination and examination of the neck examinations. Now, clinical presentations of the hyperthyroidism includes weight loss, um, despite increased appetite. This is because, like we saw, um, hyper the thyroid hormones actually increase beta metabolic rate. When that is too much and exaggerated, you find out that metabolism increase drastically, and this could lead to weight loss. You could also find patients with heat intolerance, excessive sweating. Patients can have palpitations, tachycardia, that's a heart rate of greater than 100 beats per minute, or atrial fibrillation. This because the thyroid hormone actually increases the sensitivity of the beta adrenergic receptors to catecholamines, norepinephrine, and the epinephrine. And this, if it's exaggerated, can lead to an increased heart rate, and then patients can come down with these things. Tremors, anxiety, irritability, insomnia. Yes, patients can also come down with that because of uh, a, like an hyperactive nervous system, exaggerated neurotransmitter discharge, and all that. Now, patients can also come down with diarrhea, frequent bowel movements, obviously, because of the hyperactivity of the smooth muscles of the bowels. Patient can also come down with fatigue and muscle weakness. Now, on examination, we can find that patients can have goiter, which could be diffuse or nodular exophthalmos, especially in Graves' disease, lead lag, pretibial myxedema, also in Graves' disease, hyperreflexia or fine tremor on neuro or nervous system examination. Now, when you find this is not actually enough to arrive at a diagnosis. We also need to further do investigations, and some investigations to be done include blood tests. Blood tests like um, test for the thyroid stimulating hormone. We expect to find a decreased level of thyroid stimulating hormone. We're expected to also find elevated free thyroxine and or also elevated triiodothyronine. Then also, thyroid antibody tests were expected to find um, thyroid stimulating hormone. Okay, okay, okay. We're also expected to find thyroid stimulating hormone receptor antibodies in Graves' disease. We can also find anti-thyroid peroxidase also antibodies. Now, another investigation we can do is the imaging studies. We can do a thyroid ultrasound. This is to assess for nodules or goiter. We can also do the radioactive iodine uptake. There's diffuse uptake in Graves' disease. Also, can be focal uptake in toxic nodules. Moving on to the treatment. Okay, so when we've confirmed and found positive findings during our investigations, the patient can be treated with antithyroid medications like carbimazole or propionate to inhibit this hormone synthesis. You can also administer beta blockers like propranolol for symptomatic relief of the tachycardia and tremors. Radioactive iodine, as the 131, it destroys overactive thyroid tissue. So this can actually help in the management of a patient with hyperthyroidism. Also, surgery is an option. The procedure, thyroidectomy for large goiters to compress symptoms, or also for in patients that have intolerance to medications. Now, while medications are being given, we have to ensure monitoring. And what are the things we monitor? We actually have to monitor regularly the thyroid stimulating hormone, do the assays for them, the thyroxine, the triadyl thyronine levels to assess treatment response. If it's working, you know, okay, you're making progress. If it's not working, you actually have to switch medications. Now, moving on to hypothyroidism. Now, hypothyroidism is a condition characterized by insufficient production of thyroid hormones, leading to a hypometabolic state. As a recap, we saw that hypothyroidism leads to a hypermetabolic state. That's why we have disorders and symptoms in the cardiovascular system, palpitations, tremors, sweating, weight loss, and all that. Here in hypothyroidism, we expect to find something different clinically. Patients are presenting differently in hypothyroidism. Now, before we look at the clinical presentation, some causes of hypothyroidism includes the Hashimoto's thyroiditis, which is an autoimmune destruction of the thyroid gland. Iodine deficiency, although it's rare in the UK because the iodized salt is actually common, so you wouldn't really find iodine deficiency. Iatrogenic causes like post-thyroidectomy, radioactive iodine treatment. Yeah, these things can actually cause insufficient production of thyroid hormones. Medications also can suppress the production of thyroid hormones. Now, medications like lithium, amiodarone, yeah, it can actually suppress the production of thyroid hormones. Also, it's not here, but disorders in the pituitary and hypothalamic axis, any disorder there can actually affect the synthesis and production of the thyroid hormone, leading to hypothyroidism. Like we said during our discussion on the hyperthyroidism, you have to take a detailed history, right? Then do a very comprehensive exam before moving on to the investigations. Now, a patient with hypothyroidism would likely present with fatigue, lethargy, and weakness. Patients would can present with weight gain and cold intolerance. This is because of a very, very decreased basal metabolic rate. Patients likely to present with constipation because of decreased bowel movement. Dry skin, hair loss, and brittle nails are also common in patients with hypothyroidism. Patients can also, surprisingly, well, not really surprisingly, but then depression, poor concentration, and memory impairment can be features or clinical presentations of hypothyroidism. This is because the decreased levels of neuronal activity, decreased or insufficient thyroid hormone can actually reduce the neurotransmitters that are supposed to be released in the central nervous system, and this could lead to depression and the poor concentration, the nervous symptoms. Okay, okay. Um, Now, okay. Also, a patient with hypothyroidism can present with menorrhagia, menstrual irregularities, and then also bradycardia, goiter too in Hashimoto's thyroiditis, because the thyroid hormone, the thyroid gland rather, is trying to compensate for the decrease in the thyroid hormone. Then myxedema, as in non-pitting edema, can also be what we find on general physical exam of a patient with hypothyroidism, delayed tendon reflex also, and hoarse voice. Some investigations to do in a patient with hypothyroidism include some blood tests, and you would find an elevated thyroid stimulating hormone, which usually indicates primary hypothyroidism. We're also going to find a decreased free thyroxine also in the blood. Then thyroid antibodies, the anti-TPO and anti-thyroglobulin antibodies in Hashimoto's thyroiditis are also seen. Other findings, I didn't put them here, but other findings include the you can find hypercholesterolemia, you can find anemia. Okay. You can find anemia. You can also find hyponatremia in severe cases. Now, the treatment. Okay. Levothyroxine is given for a patient with hypothyroidism as the replacement of thyroxine. This, it's worthy to note that we start with low doses. Okay. Okay. Start with low doses. Then we have to also titrate based on the thyroid stimulating hormone levels, targeting the normal range. And also, it's important to monitor the thyroid stimulating hormone levels every 6 to 8 weeks. Okay. Every 6 to 8 weeks until stable, then annually. Lots of activity on the chat box. Okay. I'm tempted to see what's going on. Okay. Patient education is necessary because while on levothyroxine, patient is expected to avoid calcium or iron supplements because this can reduce the absorption of levothyroxine, and that's that's bad for patient management. Now, in conclusion, thyroid disorders are common and can present with a wide range of symptoms. Accurate diagnosis and appropriate management are essential to prevent complications and improve patient outcomes. Hyperthyroidism and hypothyroidism require tailored treatment strategies, and ongoing monitoring is crucial to ensure optimal thyroid function. At this point, thank you all for listening. I'm grateful for this opportunity.
And thank you. I just want to say a big thank you to everyone that is here. We organize these things, but they only become of value when people take advantage of these opportunities.